Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongom egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eneagizijig, enekukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Bonjour, bienvenue, hello, and welcome to November's edition of the Department of Family Medicine Grand Rounds. My name is Doug Archibald, and I am the Director of Research for the Department of Family Medicine. And it's with great pleasure that I get to introduce three speakers for this morning's Grand Rounds presentation. And I'll start with introductions, and then I'll turn proceedings over to our speakers. So first of all, Peggy Kleinplatz is a professor in the Department of Family Medicine and cross-appointed to the School of Epidemiology and Public Health in the Faculty of Medicine here at the University of Ottawa. And she is a certified sex therapist and sex educator. She'll be joined by Yassie Pirani, who comes to us from Vancouver this morning, so she's got quite an early start. And she works with the Canadian post-SSRI sexual dysfunction, or PSSD, Society and Education, Advocacy and Research, and also specializes in supporting patients with PSSD at the Willow Leaf Counseling. She collaborates on the Share Hub project at the University of British Columbia to improve healthcare outcomes. Her work equips both the public and professionals to better support those living with PSSD. As well, Emily Rice, who's coming to us today from southwestern Ontario, is a member of the Optimal Sexual Experience Research Team of the University of Ottawa and a registered psychotherapist in the province of Ontario. Her research has examined the experiences of those with PSSD, and she works with the Canadian PSSD Society. So Yassie, Emily, Peggy, welcome. I'll turn things over to you.
Thank you.
Thank you.
Thank you.
All right, I believe we are sharing, Peggy, so I'll let you take the lead.
Thank you very much.
Emily is controlling the sharing of slides, so I'll just say next, please. Next. I have no conflicts of interest to declare. So I'm going to be giving you a bit of the narrative background, and you'll get more of the research from Yassie and Emily. In 1987, Prozac came on the market. It's people in my line of work, clinical sexologists, that is the sexual medicine and sex therapy specialists, and our patients who act as the canaries in the coal mine whenever a new drug comes out. So we're the first ones to hear from our patients about adverse sexual side effects. Even today, I don't think the gastroenterologists are aware that the PPIs cause low sexual desire, but the sex therapists get it quickly. In 1991, I was at the conference where Dr. Pirani, a clinical sexologist in Quebec and psychiatrist, said, you know, it's been 4 years and it's become so obvious that Paxil prevents orgasm in men and in women. Let's start using it to treat premature ejaculation. And his patients were thrilled that after years as premature ejaculators, they couldn't have orgasms at all. It was finally published in 1994. Next slide, please. So since 1991, where Dr. Assadian released the news, all of us in the field have very much been aware of it. You'll see different stats on the extent of SSRI-induced sexual dysfunctions. The one that most sex therapists trust is roughly 80 to 80%, 88% of individuals using SSRIs will experience either low arousal or low desire or difficulty with orgasm or all of the above. If the individual is also using hormonal contraceptives, it generally goes up from about 80 to 88% to 100%. We're doing a study on that right now. If any of you are interested in collaborating, please give me a call. When we see these numbers with just about all the SSRIs and SNRIs, with the exception of Wellbutrin, as you know, normally you start them at one dose, it goes up at 2 weeks, and then at 4 to 6 weeks, you're done ramping patients up. And when people discovered this was a problem in the early 1990s, remedies were proposed. Try drug holiday, lower the dosage, add bupropion, or switch to a different SSRI or SNRI. When none of this worked, the advice was slowly to taper people off over a 2 to 6 week period so as not to create SSRI withdrawal syndrome. This did not work. I still see patients who have been on the same drug for years and someone's just added bupropion to help take away the side effects. It does not work. But what's even more dangerous is tapering patients off over a 2 to 6 week period. That is part of what helps to create PSSD. So in the world that clinical sexologists live in, we all know that the tapering needs to be done over a 6 to 9 month period. Next slide, please. And if it's done more quickly, there will be problems. So here are the symptoms that we see of SSRI or SNRI-induced sexual dysfunction. And we see them reported subjectively. You also see objectively the absence of nocturnal erections. You see genital anesthesia, and Yassie will talk to us more about that. Next slide, please. So PSSD is enduring SSRI-induced sexual dysfunction even after the medication is discontinued. It's very much an underreported iatrogenic syndrome. Most of our patients don't even realize the connection between, in my office typically, low sexual desire and the timing of the initiation of SSRI treatment. I'll also point out that which drug matters. So in 1991, SSMF first reported that Paxil prevents orgasm. Some of these drugs prevent orgasm, some of them prevent arousal, some of them prevent desire, and some of them will do a triple whammy on all of the above. And they usually make the attempts to have an orgasm so laboriously that not only does it stop orgasm, but it makes arousal take forever. And that means that it affects desire both directly and indirectly through utter boredom and tediousness of attempting to have an orgasm when it's just not going to happen. So you can think of this as comparable to tardive dyskinesia, which is induced by antipsychotics. We've known about that since the 1950s. Similarly, PSSD is induced by SSRIs and SNRIs. Next slide, please. So more and more, and especially this week, and Yassie will be telling you more about that, PSSD has come to be recognized and classified in the various countries that use, for example, the DSM, by Health Canada, by the European Medicines Agency. Next slide, please. And the scary part is that it can affect anyone of any age, that it doesn't require years and years of being on an SSRI or SNRI before it happens. It can occur after just a few doses. It can have a severe impact on the quality of life. In some cases, we don't know how many resolve spontaneously, but many persist indefinitely. We're seeing studies coming out that show 20 years worth of PSSD. And for people who are depressed to begin with, discovering that you can no longer enjoy the sexuality that was an important part of your life before can lead to suicide. And there is no cure or effective treatment, just prevention. Next slide, please. So what do we do? It's important that before putting your patient on an antidepressant, check for their history, see if there is a baseline level of sexual functioning, and monitor to see what happens next. Are there changes in genital sensation during treatment? Are there changes in genital sensation post-treatment? Next slide, please. And if you can, avoid prescribing antidepressants in the first place. Since 2011, there have been a series of meta-analyses showing that the alternatives actually work better at the 6-month mark. Simple things like walking. We know our patients who are depressed don't generally feel like going running or running a marathon, but very often they can be induced to do simple exercise. Psychotherapy seems to work without the sexual side effects, or of course Wellbutrin. But in the last year and a half, there have been a series of studies showing, well, actually, just plain walking seems to work better than even psychotherapy alone, or the SSRI alone. And walking works about as well as psychotherapy combined with an SSRI, or most likely better. And not just at the 6-month mark, but even at the critical 2-week mark, when we're really worried about patients acting on their suicidal impulses. Also, our own Dr. Barbara Farrell at Bruyere is the queen of deprescribing, and you might want to go to her website, deprescribing.org. Also, you might want to take a look at utro.com, who describe in vivid detail how to deprescribe the SSRIs and SNRIs. They have their own YouTube channel. And they're very clear about the importance of hyperbolic tapering very, very slowly. That's harder to do in Canada than in countries like the UK or Australia, where the SSRIs or SNRIs are available in a liquid form. And it's easy enough for the pharmacy to make it available in liquid form so that patients can literally just take one drop less every day. Here, your best friend is the compounding pharmacist who can help you slowly engage in hyperbolic tapering. Next slide, please. So before initiating antidepressant treatment, you want full informed consent, warning patients about the sexual side effects. As I said, assess baseline functioning, monitor sexual functioning. When you see an adverse report, absolutely report it to the Canada Vigilance Program. When your when your patients come back concerned, you're going to validate their experience rather than saying, oh, it's just your depression reasserting itself. When necessary, refer to the specialist in sexual medicine and sex therapy, and they're going to need psychotherapy to deal with getting support and grief counseling. As I hear myself speak, I'm hearing this sounding quite dire, but I think Emily and Yassie's research will reaffirm that. Next slide, please. So a lot of research has been done. A lot more needs to be done using both public health and public policy lenses, and with the cooperation of Health Canada, who've already begun to express their concerns. Next slide, please. And I want to thank Yassie for providing a shareable graphic KTE tool for patients and providers. I had to ask her what you're supposed to do with the QR code, but I trust the rest of you know. Next slide, please. And here are just a few references. And if you'd like to contact me, you can't do that by email, but there's my phone number. And you can reach me at 613-563-0846, Monday to Friday, noon to 5 p.m. I really do answer my own phone, so feel free to leave a message if you'd like. Optimal Sexual Experiences is the URL for my research team, and you could also contact the team through that website. Next slide. So I'm going to say thank you, and I'll be available after Yassie and Emily conclude. Feel free to ask your questions in French or English. And I think Emily is up next. Oh, I'm sorry, Yassie is up next.
Wonderful, thank you. That was great, Peggy. Appreciate that introduction. I have no conflicts to declare. So I'm going to share a little bit more about the condition what I see in my clinical practice. I'm going to share some important updates that we've had in the PSSD world in the last few weeks, and some results from some research I published, as well as some results from a study I'm working on right now. So, as Peggy mentioned, there's a range of sexual symptoms that people experience with PSSD. For some people, they present while on the medication. For some people, they present upon the discontinuation. For some people, PSSD presents the second or third time they try an SSRI. So just because they've safely used this class of medications in the past doesn't mean that future treatments will mean that they might not get PSSD. It's kind of each time treatment begins, there's a risk. There's also a range of non-sexual ancillary symptoms that people experience. I see it, as often sort of broad sensory dampening in various ways, emotional numbing, anhedonia, blunted affect. People experience depersonalization, a range of cognitive impairment symptoms like memory issues, um, sensory problems involving skin, smell, and taste. Emily will go into more of some of those non-sexual ancillary neurological symptoms in her research that people report. But yeah, Peggy, I think, sees clinically more kind of the population of folks that still maybe have some of their sexuality remaining or some of their sexual functioning remaining, and then therefore would go see a sex therapist. For myself, I see some folks who have a little bit of their sexuality or sexual functioning remaining, although it's obviously impaired. And then I also see a lot of people who would never go to a sex therapist because, yeah, that's so far from what there would be possible for them based on the just really the whole collapse of their sexual function and the presentation of these non-sexual symptoms that are their main source of distress. Next slide, please. A couple of good updates. The Society of Obstetricians and Gynecologists of Canada has worked with the Canadian PSSD Society to put an information page on PSSD on their Sex and You website. So that's a great, another shareable tool, an information page for healthcare providers and patients. I trust you'll all have access to that link, to the link when the slides are made available, and the recordings made available. Also, the Sexual Information and Education Council of Canada, CCAN, has a new page on their website as well about PSSD. And yeah, both of those are brief but comprehensive overviews of the condition that help with, yeah, kind of education and information sharing. Next slide, please. The Malaysian government, just on the 14th of November, has issued a robust a robust warning about the risk of PSSD with this class of medications. The warning encourages a proactive counseling mandate. Unlike passive warnings, this kind of directive requires clinicians to proactively counsel patients on this potential risk and advise them to monitor symptoms and encourage prompt reporting to the National Pharmaceutical Regulatory Agency. And this presents a higher standard of informed consent. This warning also has a robust clinical description of PSSD in it, unlike the warnings that we've seen from other countries that kind of don't go into depth. And it also encourages physicians to proactively inquire about PSSD symptoms in their patients and encourages physicians to report all suspected adverse events related to SSRI and SNRI containing products. We, Health Canada, the FDA, the EMA, these other bodies that we can report adverse events to. It's actually a diagnosis doesn't need to be made in order to report a suspected adverse event. Next slide. So a lot of large media news outlets have covered PSSD in depth. As you can see, yeah, The Guardian, Toronto Star, New York Times, BBC, Global News. However, despite all this media attention, clinical awareness remains really low. Patients often face disbelief or misdiagnosis and frequently encounter challenges with being understood and heard and taken seriously when they present these symptoms. Also, PSSD symptoms are often wrongly attributed to depression or another mental health problem. Seems like this problem has gone under the radar for so long, largely due to stigma, shame, and embarrassment. Next slide, please. This past Sunday, the cover story of the New York Times Magazine was about this condition. There was a landmark long-form investigation into PSSD and the enduring long-term consequences of the condition on patients' lives. This article has really changed the sphere of debate about the seriousness and and persistence of PSSD. It's also significant because it really reports the emotional anesthesia and total collapse of ability to feel emotions, not just romantic emotion, but all emotions overnight, that I see, in my clinical practice. And that is also mentioned in the literature. And highlights that this condition happens for people who were not prescribed antidepressants for depression. So really clearly showing that this isn't just depression returning, which it has been dismissed as for a long time in some spaces. Next slide, please. Yeah, so PSSD has been hard to study due to underdetection and underreporting. One study estimates the risk of PSSD at 1 in 216 patients who took serotonergic antidepressants. However, to participate in the research, participants had to have ED, seek medical care for ED, then obtain a prescription medication for it, thereby likely missing many affected individuals. And the study excluded a broader diagnostic spectrum of PSSD, which overlooks men who do not have ED but suffer from other severe sexual dysfunctions, such as anorgasmia or genital anesthesia, or do have ED but also experience, other symptoms that prevent sexual activity, and then thus would never seek ED treatment. Another study that I had the fortune of being a part of and authoring helped give us another number about possible frequency and prevalence. So I was lucky to connect with a very interdisciplinary team, including partners in medicine, epidemiology, and pharmacology, as well as patient perspectives. So I had the fortune of connecting with Dr. Travis Salway, an epidemiologist at SFU, who is about to launch a binational survey called the Unicorn Survey in Canada and the US. And agreed to add a few questions about PSSD onto his survey about sexual minority experiences. Sexual minorities experience a prevalence of anxiety and depression about 2 to 4 times greater than heterosexual groups. While this is unfortunate, it did present an opportunity because this is a sentinel population, which means it's a population that has a greater prevalence of mental health conditions for which psychiatric medications are indicated. Next slide, please. So in 2022, the survey was launched. The age range was 15 to 29. Almost 10,000 young people were recruited over the course of 6 months that year. And an important strength was nobody came to the study expecting to be asked any questions about PSSD. In fact, they didn't even expect to see any questions about psychiatric medication. So, in terms of measures, we asked participants if they'd ever taken and then subsequently discontinued antidepressants. In Canada, over 82% of antidepressant prescriptions are SSRIs and SNRIs. So our comparator group were anyone who's ever taken and then subsequently discontinued other psychiatric medications, such as sedatives and antipsychotics. So the cardinal symptom of PSSD is genital numbness or genital anesthesia. So we use the term less feeling in your genitals when having sex, not something you would attribute to the underlying conditions for which these medications are indicated. And we're not aware of people who are not taking these medications reporting genital and numbness or genital anesthesia by virtue of having an underlying condition such as depression or anxiety. Next slide. So to be extra cautious, we excluded any participants who had a history of genital surgeries, including hysterectomy, because those surgeries can have an effect on genital sensitivity. And then we excluded anyone who had not had sexual experience because that cardinal symptom is about genital numbness, and people may not be able to recognize the symptom without having partnered sexual experience. So we were quite cautious with those exclusions, and then we adjusted in sequential multivariable models for confounders, including age, sex assigned at birth, previous use of gender-affirming hormones, and other gender-affirming procedures, and adjusted even for severity of depression. And we removed anyone who had not completed those questions or anyone who had not taken a psychiatric medication out of our sample. And that left 2,179 young people who had any past or current use of psychiatric drugs. For this analysis, we're comparing two groups, those who ever took antidepressants and stopped, and anyone who ever took another psychiatric medication, but not antidepressants and stopped. So after adjusting for all of those confounders that I mentioned, past and subsequent discontinuation of antidepressants, next slide, please, was associated with 14 times increased odds of persistent genital hypoesthesia or genital numbness, and 13% reported persistent loss of genital sensation as compared to 1% of past users of other psychiatric medications. Next slide. So of course, there's limitations that are important. We'll start with measurement. So we used broad categories of psychiatric drugs for specific medications. So you might say, well, you just asked about antidepressants. That's only 82% of people who take SSRIs or SNRIs, who in that class, if they're taking the class of antidepressants. Well, if that's true, we would have underestimated the odds ratio. That would have diluted the effect. And the study team thought it was a strength that we were using self-report, although there's concerns around, oh, well, do these participants actually understand what, we mean by genital numbness? The only other study, I already mentioned that. Yeah. And so, there's also the cross-sectional design. We couldn't capture duration of symptoms, and symptoms need to persist for 3 months post-cessation for patients to obtain a diagnosis. And we have to keep in mind recall bias. We don't have data on pre-treatment, baseline data on pre-treatment. But notwithstanding these limitations, we're quite proud of being able to generate these estimates and hope that they'll move the dial forward and bring more research and attention onto this. Next slide, please. So I'm also part of the SHAPE project, the Sexual Health and Genital Pelvic Pain Knowledge and Empowerment Hub, which is a national initiative focused on improving women and gender diverse people's access to evidence-based information and treatment for sexual difficulties and genital pelvic pain. So we had the opportunity to do a research priority setting survey in partnership with the Canadian PSSD Society in order to identify research priorities of patients and understand symptoms and experiences of patients. So we worked to develop the survey, it represents the largest survey of patient experiences with PSSD and helps address an important evidence gap in the field. Next slide. These results are unpublished. We're working on a manuscript right now. So we found that 96% of patients reported no prior counseling about any risks to sexuality, let alone PSSD, let alone the persistent problems that endure post-cessation. 84% of participants reported suicidal ideation related to their PSSD. 93% of respondents reported extreme or significant impacts on both their quality of life. 91% reported extreme or significant impacts on interpersonal relationships. 64% reported extreme or significant impact on ability to work. And symptom duration for 20 years post-drug cessation was reported as well, for up to 20 years. Next slide. 3/4 of respondents reported decreased ability to feel empathy, as well as appreciation and connection with art and music. 87% reported emotional blunting. 64% reported decreased ability to feel the effects of substances such as alcohol, caffeine, or nicotine. 70% reported short-term memory impairment. And 39% of participants were prescribed antidepressants for another purpose aside from depression. So really showing that, and it aligns with what I see in my clinical practice. A lot of people end up on these medications for, sleep issues, OCD, IBS, not depression. They never had sexual dysfunction, never had these problems, and all of a sudden they have this. So it's very clearly not attributed to the underlying condition. And the top research priorities identified were treatment development, increased funding, knowledge translation, and understanding the quality of life impacts. Um, I'll acknowledge that a lot of, we recruited participants through, online PSSD communities, and that often, in those spaces, often it's people who have are on the more severe end of PSSD. A lot of people who have the milder loss of sensation or milder drops in libido, they, probably wouldn't be online filling out these surveys, et cetera. So yeah, this kind of probably represents kind of the more sort of severe end of the spectrum, but it's really real nonetheless for this cohort of patients. Next slide. Um, what I see in my clinical practice is the impact of PSSD. Of course, it varies for people, but for many, it is catastrophic. Patients experience, this loss of a really important aspect of their humanity, their sexuality, as well as their emotions. For some patients, some people it's just a sexuality, and for some people they have these non-sexual symptoms. They often experience a medical trauma due to the lack of informed consent and then lack of access to any follow-up care. And then also from being disbelieved and having their experience dismissed. And misdiagnosing PSSD as psychological or psychosomatic can compound the suffering and lead to self-blame and further alienation. It can affect identity and self-worth and relationships. A lot of patients really struggle to explain the condition to people or being understood. Life goals can be really majorly affected. For example, family planning. A lot of patients, make the comparison to forced sterilization. Um, Extreme despair is really common, and disenfranchised grief with a loss not being socially validated. Um, some patients draw parallels between their experience and sexual violence, informing the power and authority differentials, the shame experienced when speaking out, societal minimization, and profound shame. Addressing the ancillary non-sexual symptoms is super important, as well as the sexual, because they can actually get in the way of being able to work and participate in society in really important ways. Next slide. So in terms of patient support, some things I've learned from, my work over the last 5 years, specializing with this population, super important to validate patients, their experiences and emotions. It may be grief or anger. It's really to be grief is to be expected, and worsening mental health is very common. Patients really need to, the folks around them to acknowledge that their trauma is real, their experience is not their fault, and that it's not a psychological problem. So really important to avoid minimizing or dismissing. A lot of patients have already experienced a lot of invalidation, which can exacerbate their distress. They just need to be believed. Also important to manage expectations. Honestly, some people do recover partially. Some people do have improvement over time, but a lot of people don't improve, unfortunately. It's also important to refrain from saying it's rare. Often it just gets dismissed as rare. We don't know how common it is. We have some preliminary research we've discussed, but for example, I've talked to 25 people in my province in British Columbia who are sufferers. So, that just goes to show. I'm sure there's a lot of others who I haven't talked to who are also here. So. Lastly, professionally run community groups are desperately needed. Some online groups exist, but they're not institutionally supported, moderated, or funded. And so, having some, more community spaces for patients to connect with each other and would be really valuable. Unfortunately, don't exist yet. So, hoping to see that at some point. All right. Emily will kind of present some important research that we have that kind of, highlights some important aspects of the condition as well. Turn it over to you, Emily.
Thank you, Yassie. So now I'll spend these last 10 minutes just talking about a study that was conducted with myself and Peggy, along with some other members of the Optimal Sexual Experiences research team. And we were really looking to understand the experiences of people with post-SSRI sexual dysfunction. I have no conflicts of interest to disclose. So we conducted a phenomenological study, and we recruited 10 key informants who self-identified as having PSSD. I conducted semi-structured interviews with each of the participants to understand their experiences with being prescribed an antidepressant, using an antidepressant, and withdrawing from an antidepressant. And the results that I'm going to share with you today are direct quotations from the participants and conclusions and best practices reported by the participants. So a lot of this is similar to what you've heard from Peggy and Yassie, but I think important nonetheless to share that, to just further back up that it's coming from these participants, these patients with this condition. So just briefly, this was a list of the different antidepressants that the participants were using. And some of them were on one antidepressant, some of them were on up to, I believe, 5 different antidepressants over the course of treatment. And briefly, these are the 8 themes that were uncovered, but I'm going to go into more detail on each one of those now. Excuse me. So the first theme that emerged was the side effects and effects of withdrawal that the participants experienced. And these, we found that the side effects kind of fell under one of 3 different categories, one being physical symptoms, such as headaches, chronic pain, brain and body zaps, and then psychological effects, including cognitive fog, emotional blunting, memory loss, and then, of course, sexual side effects, including erectile dysfunction, anorgasmia, genital numbness. So again, just reaffirming what Yassie was saying, that while, yes, there are a lot of people who present only with sexual side effects, some people only with cognitive side effects, but or some of them have everything. And just again, reaffirming the more research we're doing on this, the more we're realizing that that yes, this is, sexuality can be affected, and that's important, but there's also these other side effects as well. And then it felt important to differentiate between the side effects and then again, the suffering that was experienced by these participants as a result of these side effects and effects of withdrawal. Participants used words such as lobotomized, zombie-like, living death, to describe how they felt as a result of losing their emotional range or their sexual functioning. And a lot of people too reported just, being horrified and tormented with their side effects, every day waking up, many of them described waking up, every day and, just hoping that they would feel better and just like lying in bed, waking up and still feeling the numbness in their bodies, or other symptoms and just feeling tormented and reminded of their side effects. And then this was another theme that emerged, which Yassie was talking about a little bit, which is the relationship between the participants and their physicians when they were trying to receive support. So the participants would usually seek support when they were first on the medication and experiencing side effects. And then they were also trying to get support from their physicians when they were withdrawing from these medications and experiencing withdrawal. So, all the participants, reported trusting their physicians. And then each time they would, go to receive support, again, as Yassie was sort of mentioning, the participants were told, like, I've never heard of this before, or like, I don't know what you're talking about. It's it's only your sexuality. Is it really that important? Oh, this is a sign that your mental illness is actually really real. We need to get you back on these drugs. Or uh, can we try a different kind of antidepressant or a different dose of antidepressant? And ultimately, all 10 of the participants reported as well that they were not informed in advance of these side effects or effects of withdrawal. And so ultimately, the participants were trying to trust the physician each time they went for support, but were ultimately all let down, and that sort of led to this mistrust in their physicians over time. And so as a result of this, the participants felt quite alone and felt like they were the only ones they could rely on. They had to try to self-engineer how to try to potentially get better. So many of them became, like fervently were searching for answers, for support, reading every article they could on this, asking questions in online support groups, monitoring their symptoms, keeping like Excel spreadsheets of symptoms over time, things like that. And ultimately, through this process of like self-research and understanding, the participants really became their own experts on their bodies and on their sexuality and the importance of that for them. And this theme kind of goes in line with the trust and mistrust in physicians. That each time that the participants either went to their physicians for support or they went, online for support or resources, again, each time they tried to find support or they tried a new supplement or a different dose of an antidepressant or a different antidepressant or whatever it was they were doing, they experienced this degenerating spiral of hope and hopelessness. So again, each time they reached for support, they felt hopeful for things to get better, but then were ultimately let down because things didn't change, or in fact, things sometimes became worse. And they felt hopeless and they just vacillated between like, okay, I'm gonna put all my time and energy into this, um, or like I can't do this anymore. I can't try to figure this out anymore. I'm done. And again, um, as was discussed with Yassie, the participants, as a result of just what they were hearing from their physicians, you know, um, I've never heard of this, or like, is it that big of a deal? Those kinds of remarks really left the participants feeling disillusioned and disconnected from themselves, and like they were really just like questioning their realities and their experiences, and kind of asking like, okay, wait, am I experiencing this? Is it that big of a deal? And that's what this theme represents. And as well, another theme that emerged from how the physicians spoke to the participants about this, the participants really felt like their sexuality was being silenced. They were being silenced or dismissed. And they just kind of felt like, if my doctor won't listen to me, who's going to listen to me? So just really feeling like, they were shouting out into the abyss, essentially, like, asking for help, asking for support, but with kind of no response or no one really hearing them. And ultimately, the participants felt alienated in the world. So as a result of just not being heard or understood by the physicians, they felt alienated. But again, a lot of them reported that, I think as Yassie mentioned, that friends and family, for a lot of participants didn't really understand or validate their experience. So that also left them feeling alienated. And as well, a lot of my participants were in their 20s, 30s, 40s. And, we're talking about, wanting to the friends and friends around them were dating or getting married or having children, talking about dating and sex and these kinds of things, right? Which all these participants really question if they would be able to have kids, period, or maintain long-term relationships. So they were just left feeling very, very sad and very alone and disconnected from their peers. And so here are the themes. Just again, we identified as well like relationships amongst the themes. So, for example, as I mentioned, this relationship with the physicians and the participants really contributed to the hopelessness, the disillusionment, and the feeling silenced and dismissed that the participants were experiencing. So these were the conclusions again, right from the participants, which were people with PSSD can undergo psychological, physical, and sexual effects of withdrawal that cause suffering, trauma, hopelessness, and alienation. The loss of sexuality alone causes psychological and social distress that needs to be taken seriously by healthcare professionals. And the lack of understanding, awareness, informed consent, and acceptance among healthcare providers about PSSD can compound the suffering and hopelessness that the participants are already, or that patients are already experiencing from the PSSD itself. And participants are just ultimately asking for more research and awareness and understanding of this condition amongst healthcare providers, and that includes therapists as well, pharmacists. So I should just briefly note that a lot of the participants also highlighted that sometimes their therapists or pharmacists were not understanding of this condition. And I won't go over this because this has already all been mentioned, but I thought it was just important to put this up here, the logarithmic deprescribing protocols, assessments of, or pre-treatment assessments of sexual dysfunction, informed consent, all of these things. But I thought it was important just to have this up here to reaffirm that what Peggy and Yassie have already said, that this is what these participants said as well. And that is all.
Well, Peggy, Yassie, Emily, thank you very much for that presentation. Very much appreciated. I'd like to remind everybody that Maharan has put in sessions evaluations. If you can take a moment to fill those in, that would be wonderful. And I can see here we've got we have a number of minutes for questions and discussion. So I'll open the floor for questions. If you don't mind, actually, I'll start. A quick question here for both Yassie and Emily, and just around demographics of your study. Just curious, were many of the participants of reproductive age, or or did you have people like from a wide range of ages, including those of post-reproductive age?
Yeah, I can jump in. So for the first study I was mentioning, that population was youth age 16 to 29.
Mm-hmm.
And the survey, the second survey I was mentioning, where we're getting more data on that range of patient symptoms, that was any 18 and above. And so we had folks from 18 to 55 years old participating in that study.
Okay, thank you.
Yeah.
And yeah, I was just pulling up the stats on my study. My study, I had 5 women, 5 men that ranged in age from 24 to 75. However, I should note there was only one participant that was 75. The average age was 38. So yeah, the bulk of the participants were between 24 and I would say like 40.
Yeah.
That's what my study.
Thank you.
You're welcome.
Thanks, Doug.
Yeah, go ahead, Owen.
From talking with participants, did you come up with any practical tips that us family doctors should provide? I've acknowledged this condition for a long time, but have you any new tips, that maybe anecdotal evidence that we could share with our patients who may not be able to afford psychotherapy, maybe have had a history of relapsing when they've come off medications, maybe they got bad knees and can't exercise too much? any practical naturopathic even approaches that we could advise people on?
I can jump in. Oh, go ahead, Peggy.
I would say informed consent is incredibly helpful. Much of what Emily was describing was people feeling like they're losing their minds and feeling invalidated. But if you can warn them in advance that they may undergo these symptoms, at least you've made yourself an askable physician. They'll know that they can trust you. When they start experiencing this, they can turn to you. And I can't emphasize strongly enough the importance of deprescribing using hyperbolic tapering. And if you warn your patients, we need to get you some help quickly. On the other hand, we're not going to leave you stranded. We will take you off of these medications slowly. We will come up with a plan. They immediately feel that they can trust you and that you have their backs.
Yeah, I appreciate that. And will affirm, kind of what Peggy said. In terms of symptom improvement, it's really there's nothing that I've seen that can kind of help alleviate symptoms for people apart from time. As as we mentioned, people who often turn their bodies into lab rats to try to get better. And I've seen there's a lot of people who are doing different experiments on themselves. The really tricky thing is for some people, those, experiments that people do with different substances and pharmacological interventions can make them worse. There's a dramatic worsening of symptoms that can happen. Patients call them crashes. So, it's I don't encourage any particular protocol apart from, kind of just the basic pillars of health, sleep, good nutrition, movement if possible, taking care of other stressors if possible, so that their body can have a chance to return to its original state. Um, but in terms of kind of the psychological and emotional improvement, that's something that we as clinicians can offer is that, recognition, validation that can go such a long way into making the person feel less alienated and understood. Although, yeah, I hear you. It would be really nice to have some kind of, intervention to support with the symptoms themselves of the condition. But unfortunately, we need more research before we can get to that place. Yeah.
Yeah, I don't have anything to add besides that.
I'm just seeing a question in the chat. In terms of informed consent, what's our best estimate of incidence of PSSD?
I'm going to say that most of my patients don't have PSSD. Yassies do. But if we're thinking that 80 to 88% of patients who are put on an SSRI or SNRI will have sexual dysfunction, even if they're fortunate enough for it to be time limited, then we need to warn them about that so we don't have more patients who end up with PSSD. Mm-hmm. And I'm still thinking about Owen's question. Let me get slightly broader for 2 seconds. One option that we have is counseling patients around their initial feelings of sorrow and dysphoria and suffering about important life transitions. Loss of a parent, loss of a job, economic difficulties, rather than prescribing an antidepressant in the first place or running for the patient who can't do it because they have bad knees. What about just offering ordinary, everyday support, which family physicians are best situated to do? Owen, I have no idea if that fits for you.
Thank you.
And yeah, I can kind of just jump in. Prevalence estimates. The existing research sort of shows there's major limitations with the two studies that are like early prevalence estimates, but right now the best numbers that we have are between 1% and and 13%. But that, of course, like I mentioned, that 13% number wasn't looking at duration of symptom persistence. And there's a number of people in that 13% that would maybe just have mild genital numbness that wouldn't even really realize until they were asked explicitly if they have less sensation in their genitals after stopping. So that would really capture maybe a lot of the kind of milder cases. So yeah, unfortunately, we desperately need more research to help us get an understanding of the prevalence. But yeah, I think it can be sort of a helpful shorthand to say we don't know how common it is right now, but it may be a lot more common than we think. And yeah, it's definitely, a real problem. It's a real risk. Yeah.
Well, thank you, Peggy, Emily, Yassie. Very much appreciated. Thank you all for joining in this rounds. Just to note that there is a special ground rounds with the CHIO, the CHIO Research Institute, and the DFM, December 10th, and we'll rejoin our regular grand rounds in the new year. So thank you all very much. Until next time.